we can approach. And it's our pleasure to invite again Professor Daphne Morishano, who will present together with his team some rare but difficult cases in the field of stroke, which of course puts our brains to think what to do in each particular case. Thank you.
Thank you very much, dear Vitaly. It was indeed a great session in the morning, and we fully appreciated your efforts. We fully appreciated your efforts as a team, and we are absolutely grateful to this very good context, which was anyhow a highlight within European societies. I think the practical part is very important, and as education, it's in our focus at every second in European Academy and also in Moldavian society. We do believe that these practical-oriented sessions are very useful. And we have prepared with my team because we know we have the philosophy to stimulate the young generation. We have the philosophy to guide them through all the paths and to support this professional development. So this is my great pleasure to introduce my stroke team, the young generation, which is doing a great job all the time. And I believe that they have done an interesting collection. So let's go ahead and listen to that. I have also an overlapping bit activities. The last part will be, let's say, question and answer session will be conducted by my dear colleague, Dr. Adam, who will be with you at the end of this I would say, interesting and good session. So let's see. Let's hope for very good feedback further on. Thank you very much.
Dear participants, dear members of Scientific Committee, thank you for joining us today in this very interesting session of rare cases of stroke. We are starting with the case of a female, 45 years old, without familial medical history, without children, which raised the possibility of infertility, known only with hypertension, but she didn't receive drugs at home for this disease. Her complaints were diffuse headache, memory loss with behavior disturbances, and most important, weakness and paresthesia on the right part of the body. The disease started around 40 years old with diffuse constriction headache with superimposed alternating hemicranias, transient paresthesia, and Raynaud syndrome. At age 44, she developed mild right hemiparesis, and 1 year later, she came in our hospital for memory impairment, confusion, dysarthria, dizziness, and paresthesia on the right part of the body. General examination revealed at the level of arms, legs, and trunk irregular net-like pattern of bluish skin discoloration surrounding areas of normal appearing skin. As you can see in these pictures, and this is the typical aspect of livedo racemosa. Neurological examination revealed a conscious patient but disoriented in time, with minor right facial palsy, dysarthria, weakness, and sensory loss on the right part of the body, with an NIH stroke scale score of 6 points. The CT scan performed showed chronic strokes in different arterial territories, like bilateral MCA and PCA, Brain MRI confirmed the CT findings. As you can see here, the chronic stroke in the left occipital lobe, also brain atrophy. Chronic strokes in bilateral MCA territories are visible together with brain atrophy. Severe brain atrophy is more visible in this flare sequence together with sequels of chronic strokes. Chronic stroke also here in the left occipital lobe together with important brain atrophy. Angio-MRI didn't show significant stenosis of the level of large vessel arteries. We can see very well the common carotid arteries, internal carotid arteries. The right vertebral artery is hypoplastic and the diameter of basilar artery is a little bit smaller, but without significant stenosis. In front of a patient with ischemic stroke, we need to have in mind the dose classification because this is very helpful in establishing the etiology of stroke and establishing the best treatment for the patient. According to dose classification, there are 5 main etiologies of ischemic stroke: large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology, and in this respect, the most frequent causes are hematological diseases, thrombophilia, vasculitis, and the last type of ischemic stroke is due to undetermined etiology, and in this case, we can have 2 or more causes identified, or negative evaluation or incomplete evaluation of the patient. In our patient, I think that we can exclude large artery atherosclerosis because angio-MRI didn't show significant stenosis or occlusion of large arteries. Small vessel occlusion also can be excluded due to the dimension of our strokes, which are larger than a lacune. And for other etiologies, we have to do other tests. So in this respect, we perform an extensive workout. The standard blood tests were normal. No kidney, liver, or thyroid dysfunction. Protein electrophoresis was normal. We performed an extensive screening for vasculitis, but everything was normal. Also, screening for thrombophilia, infectious, or cancer was negative, and lumbar puncture was also normal. So basically, all the lab tests were normal. The cardiovascular examination didn't reveal important modifications. The Doppler ultrasound was normal together with ophthalmological examination. The psychological assessment showed moderate dementia with mini mental state examination 17 points, behavior disinhibition, and executive dysfunction. Due to the presence of skin lesions, meaning livedora chemosa, we performed a skin biopsy and no inflammation was present. We were able to see only proliferation of medial smooth muscle cells and vessel shrinkage and fibrosis. So the diagnosis of non-inflammatory vasculopathy was established. So we are in front of a patient with livedora chemosa and stroke without other identified cause. So what do you think, what is the most probable diagnosis? Yes, it's Sneddon syndrome. Sneddon syndrome is a rare progressive non-inflammatory thrombotic vasculopathy affecting small and medium-sized blood vessels. It is characterized by the association of skin lesion with neurological abnormalities, especially recurrent episodes of TIA or strokes, which are common findings in this syndrome. Generally occurs in women between the ages of 20 and 42 years, which is also the case of our patient. Regarding livedo racemosa, this is similar to familiar sign of livedo reticularis, from which it differs by its shape and persistence on warming. Livedo reticularis is caused by temporary vasoconstriction, whereas livedo racemosa results from persistent impairment of peripheral blood flow caused by occlusion of small or medium-sized arteries. Neurological manifestation in Sneddon syndrome usually occur in 3 phases. First phase is only with prodromal symptoms such as headaches, dizziness, and vertigo. The second phase is with recurrent strokes, and the last phase is with early onset dementia. Livedo racemosa precedes the onset of recurrent strokes by more than 10 years, but in many instances the significance of the skin lesion is recognized only after the appearance of the stroke. The cause of Sneddon syndrome is unknown. Most cases appear sporadically, but there are some theories suggesting that possible immunological, environmental, genetic, or other factors can be involved in this syndrome. Very important is that almost half of these patients are with antiphospholipid syndrome positive. There is no specific treatment for Sneddon syndrome, only symptomatic and supportive treatment. And in this respect, we can use nifedipine for the skin symptoms, but this drug doesn't prevent cerebrovascular complications. Also, angiotensin-converting enzyme inhibitors can be used in order to treat hypertension and in order to delay the endothelial proliferation. The question that remained is which drug is the best drug for cerebral ischemic events, long-term anticoagulation or antiplatelet therapy. There is no consensus regarding which antithrombotic drug should be used in order to avoid the occurrence of a stroke. Some specialists are suggesting that patients with Sneddon syndrome without antiphospholipid antibodies should be treated in a less aggressive manner using antiaggregants like aspirin, and patients with antiphospholipid antibodies should receive anticoagulants. But even with heart valve involvement, antiplatelet therapy was not inferior in comparison to anticoagulation. And always, the risk of microbleeds and intracerebral bleeding must be taken into account. Corticosteroids, cyclophosphamide, and azathioprine have been reported ineffective in treatment of Sneddon syndrome. The prognosis of this syndrome is poor, with motor and sensory disturbances, deficits in the concentration, attention, visual perception, and visuospatial skills. Thank you.
Hi everyone. Hello. So I was wondering if someone will answer some questions. Okay, nice to meet you. And it's a very interesting case. Do you
It should
have
be 3 cases, but I don't know.
yes, we will play the next
Okay.
one. But according to this one, do you have some comments? We don't see such cases at all at such a young age, so it's very interesting for us. Can you comment?
Yes, it was interesting. It was also provoking for us, but very helpful was the skin lesion. So my advice is to examine the patient completely, not only the MRI, not only the reflexes or the Babinski sign. It's mandatory to examine completely the patient, and you can find clues on the skin or other organs. So
What's something special that that keep your mind on look to this syndrome? It was something that
no, the only thing which was special was dementia. It's dementia in a young lady, so with an impressive atrophy, and this is not very common. Yes. And when you're seeing this atrophy, the first thing is maybe the patient has Alzheimer's disease, because atrophy usually is associated with degenerative diseases like frontotemporal or other type of dementia. And in front of a patient with dementia, it's very important to look for other treatable causes, not to stop at neurodegenerative disease. This is my advice.
yeah, thank you very much. Professor Lisnik, can you go up?
No, you can continue. As the future president of our society, so why not?
It is a joke. So if we don't have any questions in the chat, we can proceed to the next case.
How many cases do you have, Adina?
3. We have 3 cases.
3.
But we
okay.
received just 2 videos. It's okay?
2 videos. The second video has 2 cases.
Okay, so we can
Okay.
play now.
Okay.
Yes, thank you.
Thank you. We're waiting.
Good afternoon. My name is Hangicel Patricia, and I'm a third-year neurology resident. And under the supervision of Dr. Adina Stan and Professor Dr. Dafin Fior Mureșanu, I would like to present you a clinical case of one of our patients and review a rare and interesting disease. Our patient was 37 years old when he first came to our clinic complaining of mild vertigo, left ear continuous tinnitus, tingling, and numbness at the left side of the body. Through attentive medical history interview, we found that he had burning pains in the hands and feet, triggered by heat, stress, fatigue, and exercise, symptoms that decrease in time. First symptoms appeared when he was 10, 12 years old and were interpreted like growth pains due to absence of physical findings. Associated, he had hypohidrosis and moderate generalized anxiety. Neurological examination was without significant findings. Vital signs were normal. General examination revealed reddish-purple skin lesions, angiokeratomas, around the umbilicus and the mouth. Patient's first symptoms started 2 months before, and he was investigated in the ENT department without pathological findings. Next symptoms, intermittent numbness on the left side of the body, determined the patient to seek neurological consult. The MRI investigation revealed white matter abnormalities in T2-FLAIR sequence. These images show the same white matter lesions in different levels of the brain. As can be observed, the lesions don't have diffusion restriction and don't enhance contrast. In the T1 sequence, there can be observed bilateral hyperintensity in the thalamus. Also, these lesions don't enhance contrast nor have the diffusion restriction. Vessel imaging didn't reveal pathological findings, no stenosis, no contrast enhancement. The diagnoses that should be ruled out in this moment are demyelinating disease, strokes, inflammatory vasculitis secondary to connective tissue disease, infectious disease, and genetic disorders. The clue for the diagnosis came from T1 hyperintensity finding in the deep gray matter nuclei, and in this respect we had to rule out the most important causes for this, like calcium depositions, carbon monoxide intoxication, lead, cyanide, and methanol poisoning, hepatic failure, intracranial hemorrhage, and encephalitis. Blood tests were normal, including calcium and part hormone level. The screening for vasculitis was negative, but moderate proteinuria was identified. Cardiac exam revealed mild mitral insufficiency, mild left ventricular hypertrophy, and also incipient cornea verticillata was discovered in the ophthalmologic exam. As many of you may already think, we thought about Fabry disease. Considering actual mild neurological symptoms associated with history of burning pain in hands and feet, hypohidrosis, angiokeratoma, and modified renal function, we had more than enough reason to test the patient for Fabry disease. Long time considered a common neurological finding in Fabry disease, the pulvinar sign raised a red flag. The genetic test confirmed Fabry disease, a severe form with no peripheral activity of the alpha-galactosidase enzyme. The patient receives enzyme replacement treatment with fibrazyme 2 vials every 2 weeks, and also clopidogrel for stroke prophylaxis and angiotensin-converting enzyme inhibitors for reducing the proteinuria. The clinical evolution after 2.5 years of treatment is satisfactory. The pain resolved, there were no other neurological events, and cardiac and renal modification stabilized. Besides every 2 weeks admission for treatment, the patient is extensively re-evaluated every 6 months and brain scan every 1 year. And now some words about Fabry disease. It is an X-linked lysosomal storage disorder which leads to accumulation of glycolipids in the endothelial and smooth muscle cells. Women can also have Fabry disease, but they may have more discrete symptoms and onset later in life. The spectrum of clinical manifestations of Fabry disease ranges from the classical to severe phenotype, even in patients with the same genetic mutation. In children, the presence of acute unexplained episodes of pain or chronic pain in the limbs, exercise intolerance, unexplained gastrointestinal disturbances, hypohidrosis, and angiokeratomas are the most common presenting signs and symptoms. Characteristic corneal lesions are seen in most affected children, even early in the disease course. Mild proteinuria usually presents later in life, but should alert the physicians to look for Fabry disease. In adults, other manifestations that allow clinicians to suspect the diagnosis include unexplained renal dysfunction progressing to end-stage renal disease, unexplained cardiomyopathy, especially left ventricular hypertrophy, and very important for neurologists, stroke from unclear causes. Adults also report unexplained fatigue and intolerance to heat. The accumulation of gliobotriosylceramide begins before birth. Consequently, time leads to burden of the cells and cellular dysfunction. Without enzyme replacement therapies, tissue are affected. Next, cardiovascular, renal, and neurological systems are irreversibly damaged and lead to considerable morbidity and mortality. Classical symptomatology is usually found in men. Mean survival without treatment is 55 to 70 years in women and 41 to 50 years in older men. Cerebrovascular complication onset is earlier in life in male patients than in female patients. Neurological manifestations of Fabry disease are burning pain with acroparesthesia and reduced pinprick sensation. Quantitative sensory testing performed in Fabry disease patients showed intact vibration threshold but impaired thermal threshold in distal extremities. These results signify length-dependent small fiber polyneuropathy, affecting mainly the small myelinated A delta fibers and to some extent the unmyelinated C fibers. Also, large fiber neuropathy is encountered in Fabry disease when there is complicated renal failure and with additional uremic polyneuropathy. Hypohidrosis or anhidrosis is a universal complaint in patients with Fabry disease, probably because of autonomic dysfunction or due to primary sweat gland disorder. Other signs of autonomic dysfunction are gastrointestinal symptoms, impaired pupillary constriction, reduced salivation and lacrimation, and no prurite. Also, auditory symptoms are often mentioned. Life-threatening symptoms, including strokes, are among the latest occurring manifestations and would cause the death in the third to fifth decade in the absence of specific interventions. Strokes can be the direct consequence of cardiogenic embolism or a combination of changes in the vessel wall secondary to glycolipid accumulation and abnormal reactivity and signaling, contributing to activation of the coagulation pathway. Moreover, patients with Fabry disease show a prominent thickening of the common carotid artery intima, abnormalities of cerebrovascular autoregulation and vasoactivity, and dysfunction of cerebral circulation with substantial cerebral hyperperfusion in the posterior cerebral circulation. Latest studies found that 4.9% males and 2.5% female stroke patients had a biologically significant mutation within the alpha GAL gene. Mean age at onset of symptomatic cerebrovascular disease was 38.4 years in male and 40.3 years in females. Frequency of infarctions in the vertebrobasilar area correlated with more pronounced changes in the vertebrobasilar vessels like dolichoectatic pathology. The major conventional imaging findings in Fabry disease are white matter hyperintensities, stroke, dolichoectasia, and tortuosity of large vessels, especially the basilar artery, and pulvinar sign, unilateral or bilateral hyperintensity of the thalamic pulvinar in T1. Diagnosis of Fabry disease is frequently delayed by several years because of non-specific nature of presenting complaints. It is often missed in women and children. As an initial test, alpha-galactosidase A activity can be measured in leukocytes, plasma, fibroblasts, or dried blood spots, but confirmation needs mutational analysis of the alpha-galactosidase alpha gene. The natural history of Fabry disease was significantly improved by the introduction in 2001 of the first specific treatment for the disease, enzyme replacement therapy, based on the administration of human recombined forms of alpha-galactosidase A. Enzyme replacement therapies stabilize and may slow disease progression, especially when started at early age, with evidence of a dose effect and benefits on major outcomes such as cerebrovascular, cardiac, and renal complications. Recently, newer therapeutic options have risen to offer an alternative to enzyme replacement therapy to overcome some enzyme replacement therapy related inconveniences. And some of these options are oral chaperone therapy with migalastat. The take-home messages are that the central and peripheral nervous system are target organs in Fabry disease. Because of this, Fabry disease may mimic many neurological disorders, such as demyelinating disease, neuropathies, and stroke. In the reported case, the age of onset, recurrent cerebrovascular events, and MRI findings led to an initial diagnosis of multiple sclerosis. However, oligoclonal bands were negative, and there was no demyelinating process in the brain biopsy specimens obtained from the lesions found in the cerebral MRI. As the study shows, Fabry disease may mimic many neurological disorders and should be considered in young patients with unexplained stroke, especially if it occurs in combination with infarction in the vertebrobasilar arterial system with angiokeratoma and proteinuria.
Adina, will you answer the questions?
Yes, there are questions. Okay, I will look on the chat.
No, till
Yes, you can
now.
ask in Romanian.
Yes. I will ask in English.
Great.
Why males live with almost 20 years less than women with Fabry disease?
Because it's an X-linked disease.
Ah, sorry. I understand. Yes.
Usually females are only carriers or.
Yes, understand.
And we are testing all the patients with stroke less than 50 years old. The test is free. It's only a blood test on a paper. I don't know if it is available in your country. And until now in Cluj, we have only 4 patients.
4 patients with Fabry?
Yes.
A lot.
The company is telling us that there are few patients, in fact, because usually the incidence should be bigger, but we discovered only 4 in the last 2 years. But we are searching for all the patients.
And the treatment is perhaps very expensive.
Treatment is very expensive. It is 15,000 euros per month. And the patient should come every 2 weeks for a perfusion. This is my patient, but there are, so one vial is more than 3,000 euros. And if the patient is bigger, then he needs more drug. It's expensive.
Yes. So there is a question, but you already answered. But in Romania, did somebody calculate
there are
it?
21, 22 patients with Fabry disease, I think. Most of them are in are with renal insufficiency, so they were discovered in nephrology. Very few in neurology or in cardiology, because proteinuria is usually the first, let's say, paraclinical finding.
Our colleagues, how many patients did we see with Fabry disease? Lena Manole from the Department of Stroke. What can you tell us? Oksana, do you know how many patients at our Institute of Neurology we see with Fabry disease?
I don't know for sure, but I think no one.
No one diagnosed. We only suppose that this could be, of course. We see such patients with neuropathies because it is a small 5 neuropathy. They present
Very
with
important, yes, it's dolichoectasia of basilar artery, which is specific. So don't think to hypertension, because maybe hypertension is due to renal insufficiency. In all the patients with dolichoectasia of basilar artery, we have to be more attentive to Fabry disease.
Yes, thank you. We'll keep in mind. If there are no questions, we have time to switch to the third presentation.
Okay.
Thank you.
But we don't have another case.
So the last movie doesn't contain 2 cases?
No, just 1.
So we escape earlier then?
Okay.
Maybe you can present a case of yours. I don't know.
From our side, we prepared, but we were prepared in multiple sclerosis. We can present a case for Adina, and she will be the expert. Will tell what this means. Okay, we have some time till Professor Kapos will come. 25 minutes more.
So you have a break here.
Okay.
I'm also on duty.
How many thrombolysis did you do
Today
today?
one.
Wow.
Today
And-
one. Until now, right now there is an M2 occlusion. We start thrombolysis, but the helicopter is ready, and the patient will be transferred to thrombectomy to Târgu Mureș. This year we have 140.
Thrombectomies or thrombolysis?
Thrombectomy 25, 26, something like this.
And all of them are done in Târgu Mureș or
They are done in Târgu Mureș or in Timișoara.
so Cluj is still not performing thrombectomies.
We have only helicopters.
But to move the patients to Târgu Mureș is faster
15
by
minutes.
car
Yes.
than by helicopter or no? Or do
Right now, my resident is thrombolizing a young lady, 47 years old, with M2 occlusion. 17 points NIH Stokes scale. How many thrombolyses do you have?
we have a lot. We can't calculate them. Oksana, do you know how many thrombolysis were done today in our clinic?
No, I don't know for sure, but I can present MRI for Adina if she will be so kind to to keep time. If you are very busy, we can.
No, it's okay.
Take a
I'm
break.
allowed the MRI, so.
Anyway, thrombectomy is a large time window, so the patient can wait 15 minutes more. Sorry. Just several minutes more. Please, Oksana.
I will try to share my screen. I don't know if it will work.
We see. What has the patient? What is his clinical picture? He's from 1951, I see, a male.
So the patient is a obese one with stop sharing. I put my stop sharing with
70 years old, male. Yes.
Yes, is a male with the history of diabetes, and in the acute phase, he have such a strange hand syndrome. It's very
Due to parietal lobe involvement.
Yes, and the patient has a history of a cancer, colon cancer, operated and radiosurgery. So the question for our images was it is a real stroke or it is something else. But they told us this is a stroke old, like
stroke.
yeah. There is one old and another one in a chronic phase.
What I saw is a stroke in the right parietal lobe and also occipital, and the stroke from parietal seems a little bit with hemorrhagic transformation in the periphery. So it's an old stroke, but the hyperintensity on the flare, in my opinion, is old hemorrhage, maybe reperfusion or something like this. And there are two arterial territories, so maybe it's a cardioembolic stroke, maybe due to endocarditis in the context of cancer, maybe because there are cortical lesions, and usually cortex is involved in the cardioembolic etiology. In fact, the third case was with the cardioembolic strokes, the third case, due to marantic endocarditis.
Yeah. Okay, but at the moment we don't have such an echocardiography. You know, we don't have something. I think maybe it was in the past because the stroke it's not so acute now.
Yes.
And the thing that was bothering me was the history of cancer and a long history of diabetes. And I was thinking, what do you recommend in a treatment for such patients?
For this patient, for secondary prophylaxis, so basically, I didn't see the angio, so the patient doesn't have stenosis, no. So it's because there are strokes.
Yes, we have ultrasound of the brachial plexus, and it's all right.
So due to the fact that the patient has true ischemic strokes in two different arterial territories, basilar or PCA and MCA, maybe cardioembolic source, it's possible, but if you don't demonstrate this, the anticoagulant treatment is not indicated. So I will choose clopidogrel for secondary prophylaxis in this patient, and I will continue to search for a cardioembolic stroke. Especially also what we can do in patients with stroke and cancer is to measure the level of factor 8. Factor 8 is increased in cancer people and stroke, and increasing level of factor 8 is associated with hypercoagulability, and if factor 8 is increased, we can provide anticoagulant treatment to this patient. Antivitamin K, not novel anticoagulants, old anticoagulants.
Yes, and I understood. And a colleague of ours on the chat asked if it could be like an abscess.
No, because it doesn't have edema around. It is visible that it's a chronic stroke due to the fact that it doesn't have edema around it, and there is also fibrosis. This is my opinion, at least. Yes.
How often do you see patients with such a syndrome, like a strange hand? It was for me, it was the first time.
I think that I saw 2 or 3 cases, so it's not very frequent, because first of all, the patients don't know how to describe this. Yes, so usually focusing more on the motor deficit, hemiparesis, do you feel the same, something like this, alien syndrome or something like this. You have to love semiology, let's say, to see the patients yourself, because otherwise the residents usually, if they are not attentive. But basically, sometimes I'm seeing the MRI, and then I go back to the patient and I'm asking, so what's the problem with your hand? How do you feel your hand? It's yours, or? Yes.
Okay, so this was a very acute situation when patient was driving, so the hand was just, very unusual looking, so it was like straight.
Yes, it means that the lesion on the MRI is a chronic lesion, so this is not the cause of the symptom. Maybe patient has epileptic seizure, or maybe you have the lesion in another place.
We saw him 2 weeks after the episode, so it could be, I think. We have Professor Ludwig here, so we can stop filling the time. Thank you, Adina.
Thank you, Adina, and wishing you to solve quickly the patients with the stroke and to go to the thrombectomy. Hopefully he will arrive in time to Târgu Mureș. And thank you. And
the patient is in time. Thank you. Thank you. Have a nice day.
Thank you. Goodbye. Professor Kapos, if you don't mind, we can switch to your interactive cases, case presentation. There's a change of treatment in multiple sclerosis. It's a very important issue, in spite of the fact that the possibilities to change treatments in our country are not so high. So we are dealing with what we can do. But anyway, we have to keep in mind that there are lots of possibilities and should know about these possibilities for our future practices. Welcome again.
Well, thank you again for inviting me and for also choosing this very interesting topic, which only partly can be addressed with very solid evidence. So much of that is what we will discuss is based on individual assessments and individual experience. So I will be happy to share that with you. If you agree, I would start the presentation by setting the scene in some way. So explaining some of the principles, and then we can proceed. It's up to you if you want to see one or two cases that I would present from my side, or if you have prepared cases, as I just saw in the previous interactive sessions, this would certainly make the discussion much more interesting for you. And I must admit that I'm not familiar with regulatory landscape in your country. So what you mentioned already, that some treatments are not available, and that will be something that we of course need to take into account when we further discuss that. So I would spend a few minutes on the key issues here. So if we want to choose a treatment, we need to try to define the prognosis of the disease. Then what is indeed our therapeutic targets? What are we aiming at? And then decide about the optimal treatment strategy. And I will just shortly mention the issue about early versus delayed, because there is seemingly still a controversy about that. And also the question, does it make sense to use the most effective treatment for the first beginning, or to escalate? And of course, then about the best suited compound. This is just a screenshot from a review presentation of Martin Torre from Barcelona in EAN that nicely summarizes the up to now more or less, I would say, established prognostic factors, at least for groups of patients. And these can be divided when we assess a patient in demographic and then environmental factors. So older age, male sex in most statistics, not being of European descent, low vitamin D, smoking, comorbid conditions, cerebrovascular disease, for example, are certainly factors that create a worse prognosis. Then we have clinical factors related to the disease. So primary progressive disease subtype is in mostly a negative issue, high relapse rate, especially in the first 1 or 2 years. short interval between first and second relapse, brain stem, cerebellar or spinal cord onset, and poor recovery from the first relapse, as well as a already high EDSS at diagnosis. If we look at MRI observations, again, most of it is quite well known and established. High number of T2 lesions, high T2 lesion volume, presence of gadolinium enhancing lesions, although this has been more controversial than most of us would expect, presence of infratentorial lesions, spinal cord lesions, whole brain atrophy already their diagnosis, and especially gray matter atrophy. Biomarkers are the high number of T2 lesions, so during the disease, also leading us to look for better treatments or other treatments. Presence of IgG and IgM molecular bands at diagnosis is an initial bad prognostic factor. High levels of neurofilament light chain in the CSF, and especially now available in serum, are also a bad prognostic factor. And high levels of chitinase in the CSF, which is not as well established, and in OCT, retinal nerve fiber layer thinning is also something that has been related to bad prognosis. Several groups have tried to put these factors, as many of them as possible, into a risk calculator that helps the neurologist to better assess the prognosis and perhaps then to take therapeutic decisions. One of those, you have certainly heard about the Rio score, a more recent, published 2 or 3 months ago, comes from a collaboration from the Barcelona and Rome group, and is called the ROAD score. And as you see, it is divided in from factors at start of initial treatment and those that are then taken 1 year post-start of the initial treatment. You see this as a relatively simple: age, time since first MS symptom in years, and the EDSS score. And then after 1 year, the number of relapses, number of contrast enhancing lesions, and new T2 lesions. And this together may result in a score of 0 to 8. And the authors have looked at the prognostic value with a cutoff of less than 4 or 4 and more. And you see that disability milestone-free interval survival was significantly reduced for those who had a score of 4 and more in this relation. So indicating that it would be good to have another and more effective treatment for these patients. Here you see also the scoring of the 10-year risk of change to a higher efficacy treatment, as you see here. And they did that in 2 different cohorts, so validated the findings in the training set in Rome with a set of patients in Barcelona. And you see the increase with increasing score is reproducible in both groups. And if we look at reaching disability milestones, what I've shown in the previous slide, you see that here also even more pronounced increase with increasing score. So the initial treatment strategy is currently under discussion, and I wanted to present the most late evidence that supports an early treatment. And this is a study done in collaboration between different MS registries in Denmark, in Italy, in Sweden, and the MS space, which is worldwide, and also the French registry. And you see here that according to the delay of treatment, irrespective of which treatment was used, so it was for all immunomodulating treatments, you see an increase of the number of patients who have a confirmed disability progression. So those with the latest, in the latest quartile of duration since diagnosis, initiating treatment, have the worst prognosis, the most steep increase in the probability of sustained or confirmed disability progression. And the same is also shown for other outcomes. And so I think in this very international and very extensive study, the question that has already been answered, of course, partly, at least for short term, with CIS studies, for example, is further supported that it really makes a difference to start as early as possible within the first weeks or months after diagnosis. And this is also reflected in the attitude. This is also work from the Barcelona group, which shows, if you look at the shift to the right, that most over the decades, since 1980 to 90, the distribution is much closer and shorter intervals since diagnosis. So early versus delayed is a controversy that, in my mind, is resolved. We need to treat as early as possible. But the question that is still open to some extent is the most effective treatment to be chosen, or should we try to escalate with better known drugs like the injectables, interferon and glatiramer acetate, and then escalate only if we see disease activity and progression. I think the rationale has already of early induction therapy and high efficacy therapy has been established since some time. Here you see a list of key arguments that you, of course, limit further damage that cannot be recovered, that you may be able to change pathogenic mechanisms in a better way when they are not as well established over the years, and that in some treatments it has been also the concept of immune reconstitution, so rebooting the abnormal immune system with a very radical suppression or elimination of the existing immune system. To my mind, this has not been proven yet, even for bone marrow transplantation or autologous stem cell transplantation, but it's still a concept that, of course, is attractive both to treating neurologists and patients. The question is, what is the target, and should this be done in general or not? And you see here what are the options. We had cytostatic agents, mainly mitoxantrone and cyclophosphamide, which are not used anymore so much. If other drugs are available, then a selective lymphocyte cytostatic agent, cladribine, oral agent, and the monoclonal antibodies, blocking monoclonal antibodies, especially natalizumab, and then the depleting, on one side, the pan immune cell alemtuzumab, and the B cell depleting treatments that have now entered center stage, and of course also hematopoietic stem cell transplantation. I think perhaps nearly definitive answer, as far as this is possible without prospective controlled studies, has been given by a recent publication by Spearman and colleagues, who compared two studies with very comprehensive registries of patients, and interestingly, both Scandinavian, Sweden, and Denmark having a different attitude. So in Denmark, the prevailing strategy was escalation, while in Sweden, the prevailing strategy across the country was highly effective DMT from the first beginning of the disease. And they compared, and you see these are significant numbers, and follow-up of up to 6 years, of course, with decreasing numbers after the first 3 years, but starting with more than 2,000 patients systematically assessed and systematically documented in these two countries. And you see here, excuse me, if we look at the time to first relapse, there is a clear and significant difference, a much flatter curve for those who start with a high efficacy treatment in Sweden. The baseline characteristics were quite similar. I don't show the tables here, but believe me, and you can look up in the paper. And in Denmark, with the escalation strategy, much shorter time and higher rate of patients who within the observation period have a relapse. And more importantly, also disability progression showed a statistically significant difference. So a confirmed change on the EDSS. You see here again a much better prognosis for those with early and intensive treatment. So in my mind, the arguments are quite strong for really choosing, if we have the option and the possibility, the most effective treatment. But of course, it has to be, the advantage has to be balanced with the risks. And in my mind, the treatments that have mostly provided a good balance between risks and this benefit of a highly effective treatment are the B-cell depleting therapies, and to some extent in JC virus negative patients also natalizumab. So we need to compare the efficacy and the risk and convenience. And for that, of course, we have controlled studies and observational studies. Now come to the discrete or the more direct questions. In the what is the choice of first treatment? And I can only provide my personal summary and what we are doing in our center in this respect. In RIS patients, the usual attitude is close monitoring, but pending studies on this matter, we usually do not treat these patients. In CIS, the official indication is given for injectables, former first-line treatments. Those compounds, especially teriflunomide, cladribine, have shown higher efficacy in the CIS patients in controlled studies, but are not officially approved. And the same is true for the rationale for other oral treatments and also anti-CD20 treatments. There is one study now going on also with ocrelizumab in this indication, but has not been completed. In relapsing MS, the standard, at least in our environment, are orals, DMF, teriflunomide, and in Switzerland and also in the US and other countries, but not in most of the European Union countries, S1P modulators as also first-line treatments. So the first-line injectable, former first-line injectables are only given in specific cases, for example, in the case of pregnancy, in order to avoid complications with the pregnancy in patients with rather low activity of the disease. The question is, in some countries for S1P modulators, and in all countries for natalizumab and anti-B-cell agents and cladribine, of course, much more for alemtuzumab because of seldom but very serious adverse events that have occurred. Should we take these treatments only for highly active or for aggressive relapsing MS? Our attitude is not to differentiate, of course, to be more active in explaining that to the patient and offering that to the patient in highly active aggressive, but also to offer this as an option, all these treatments except for alemtuzumab for patients who are early and who do not have the typical characteristics of that are associated with a more aggressive or active course. In SPMS, there is an official indication for siponimod if there are also signs of activity, and in PPMS, as you know, ocrelizumab. But the reason why siponimod should only be given to SP and not PPMS and vice versa with ocrelizumab is not really so based in our understanding of the disease, but just in the existence of the respective trials. So for me, this is a blurring boundary between these two indications and these two compounds at this moment. Some take also cladribine for this group of progressive patients, but this is still even less based on good and prospectively gathered controlled evidence. So in switching treatment, what are the reasons for switching once we have decided for a treatment and we want to continue with another treatment? It is in especially in natalizumab patients, of course, a risk mitigation in those who are JC virus antibody positive. Some rely on NIDA, achievement of NIDA. So if NIDA is not achieved, and recently we are also expanding, but more on an experimental ground, to NIDA 4 and 5, which includes atrophy, which is of course in individual patients difficult to follow exactly, and more recently, but perhaps even better substantiated in the meantime, neurofilament light in serum. The choice of switching, if persisting activity is relapses, MRI lesions is the reason, then we would prefer a vertical switch, which means to a compound that we expect to be more effective based on field studies or controlled studies. So we would switch to patients with, excuse me, we would switch to fingolimod, natalizumab, ocrelizumab, and cladribine in very few cases in our center, also to alemtuzumab. In cases of secondary progression, the question is if we started in siponimod, or if a patient enters a more progressive stage, it would be a consideration to use siponimod, but also these other two agents, depending on the country and the situation, more or less off-label. The other question that I guess you had also in mind when you asked me to present in this meeting on this topic is how to switch. So once we have decided we will switch from one drug to the other, what are the necessary baseline assessments? Especially when switching from natalizumab, it is always important and required to have a thorough imaging of the patient in order to see, especially if there are any signs of emerging PML or other complications. Some centers have used CSF, also PCR for JC virus, before they use depleting agents like anti-B cell or even alemtuzumab. But unfortunately, there are several cases in the meantime described where carryover JC virus infection, PML, occurred although CSF was PCR negative for the JC virus. So myself, I've been always propagating, doing the CSF, have now doubted more and more on that. The next question is washout time, which is a trade-off between efficacy and risk assessment. And also, do we wait until the lymphocytes or the immunologic effects have already normalized until we start with a new treatment? We tend more and more to take this small risk into account and to not extend the period of no treatment or washout too much. So usually after fingolimod, we start even with a depleting therapy within 4 to 6 weeks. And after the last dose, if we switch to anti-CD20 or for alemtuzumab, the interval is sometimes somewhat more extended. And also for anti-CD20 agents, we wait until the next regular dose would be necessary, independent of repletion, before we perhaps switch to another treatment, although the options, of course, in this height or in this class of treatments are less good. And of course, you need to establish a follow-up plan that assesses, especially for natalizumab patients, a regular MRI within 3 or 6 months after switching in order to see if there was something or a PML develops, although the baseline MRI at switch was negative. So I think we discussed that already. I would have one first case, but I'm open If you want to present your own cases, we can do that. What do you prefer? So our chairman,
Okay, if you present one case, and after that we will present our case.
Okay, so this is a young 38-year-old woman. She was a teacher, complained about pain in the left eye already in June 2016. So a typical optic neuritis with color vision also reduced since 3 or 4 days, no other symptoms, no clinical signs of infection. In the history, she had already 6 years earlier an optic neuritis of the other eye, and steroid pulse and plasma exchange was done because she did not recover immediately. At this time, she had an ambiguous finding with oligoclonal banding. So it was first judged positive, then the laboratory said, oh, most probably negative. Anti-NMO antibodies were done at this time, were negative. And 1 year later, she developed left eye optic neuritis that was treated with a steroid pulse and recovered. Again, the anti-NMO antibodies were negative. And she had, we watched this patient, we did not install a treatment because also some diagnostic uncertainty, and she had no MRIs, no cerebral MRI lesions in repeated scans, perhaps overdoing with 4 MRIs. In the meantime, there was a swelling of the optic nerve on both sides, always in the time of the optic neuritis. No other neurological symptoms, no family history for neurological diseases. When she now came in 2016, she had reduced visual acuity and also a deficit, an afference, visual afference deficit, but no other findings. So again, an isolated optic neuritis. And I hope you can see that here. Let me see if I can switch it. You see that one of the optic nerves is enhancing. I think we skipped that already here. Here on the right, you see here on the left side. And then if we look again here, this is the cranial MRI, which just believe me, I don't want to show it. It did not show any evidence of other lesions, so no cranial lesions. And then the spinal cord MRI showed 3 or 4 lesions, one of them also enhancing with contrast agent at this time. Evoked potentials had, of course, on the left eye, a prolongation, but there was also a motor evoked potential that a central latency to the left leg that was prolonged. Anti-NMO, and this time also anti-MOG antibodies negative, and a mild pleocytosis, and this ambiguous finding again of oligoclonal bands, borderline IgG index, and no intrathecal production according to the scheme proposed by Reiber. We looked also in this patient, because we had the MRIs available in a standardized fashion, on atrophy, and we saw that she had a higher rate of a reduction of the brain volume with the Siena method than the normal population here in blue, and this is the red is the curve that resulted in her case. So it was 0.76, and the upper level, at least in other groups, has been in normal individuals 0.4. So what is the diagnosis? As you see, this recurring optic neuritis with additional small, not extensive lesions in the spinal cord does not fit ideally, but would be compatible with negative anti-NMO and MOG antibodies with the diagnosis of multiple sclerosis. So what would be, of course, we treated the optic neuritis and it improved, but only after plasma exchange, but then improved completely approximately 1 month later. So what would you decide in this case? Would you indicate an immunomodulatory treatment, and if yes, which one after this history? Any volunteers from the audience?
Yes, of course.
So you would indicate
please.
a treatment?
I don't know. I'm asking somebody to respond, not only me.
Well, this is a historical case, maybe. Yeah.
Who wants to answer? Oksana, maybe you.
Again, me.
Would you treat this patient also prophylactically, or say, okay, optic neuritis, not always easy to treat. In 2 of 3 episodes, we needed plasma exchange, but full recovery?
I think I will start treatment because it's not the first one, it's the third. So, and they change the sides. And I think it needs treatment.
So that was also our opinion. So we are in full agreement, and we started the treatment with, at this time, off-label anti-CD20 rituximab. And the patient then in January 2019, I just selected this investigation, had a full recovery and no signs of activity. A total of 5 rituximab infusions in 2.5 years. But she was not tolerating it ideally and felt a little bit sick after the infusion. So she asked to change the medication. And what would you recommend in this situation? Would you switch to another treatment, stop treatment? What would be your attitude?
According to the guidelines, I think we can switch treatment, but we have another reality in Moldova because we don't have so much treatment at all. So we don't have rituximab, just some few cases when we can get him. And we have just interferon alpha, beta, and that's all.
Okay,
so we have some patients that came from abroad, and they have some other treatments, but as I know, we have just 2 treatments available in our country.
So in this case, we decided to continue on rituximab and persuaded the patient to do that, but with extended intervals. So we extended the interval to a little bit to 1 year instead of 6 months. And in the last follow-up, which was quite recently, in April 2021, she was stable and had no signs of activity and progression. And I think this is also compatible with the experience in open field use in Sweden with rituximab, and also with the experience we now have over more than 8 years in the follow-up of patients who had been treated initially, or then after the controlled phase switched to ocrelizumab. So I think the profile, the safety profile of these anti-B cell agents allows for the continuation of a treatment as long as no other complications occur. So this was my case, my first case, and I understood correctly that Professor Lisnik, that you have also prepared one or the other case that we could discuss now. I would then stop my presentation and turn to the full view of the participants.
We will invite our assistant professor of neurology, Elena Kostro, who will present mainly a diagnostic interesting case case between which put a lot of questions, especially at the beginning of the disease when you have the first meeting with the patient and you don't know where is the main lesion, in the brain or in the peripheral nerves. So, Elena, if you would like to.
Good afternoon. Good afternoon to everybody participating in this interactive afternoon session. I'll try to share my screen and present the case. Okay. Do you see it well? Do you see my screen?
Full screen.
Full screen, please.
Just 1 second. So I'll present you the clinical case of a young man, 27 years old, admitted to our department, our clinic on March 2019 with flaccid tetraplegia, areflexia, pain along the spine and limbs, and facial asymmetry. At admission, he had no remarkable family history from neurological point of view. And talking about past medical history, he remembered just a short episode of hand numbness and heavy legs sensation with resolution of these symptoms very fast, within 4 days, 4 months prior to admission to our clinic. So actually, the patient was referred to our clinic from another regional hospital, where he was admitted 1 month before because of a subacute distal weakness, which appeared first of all in lower extremities, and after that hands, plus a diplopia apparition. That's why our colleagues have performed brain MRI, but unfortunately without gadolinium administration, and they have observed periventricular demyelinating lesions suggestive for multiple sclerosis. They have done also nerve conduction studies showing typical signs of demyelination. And given all these findings, they just started post-therapy with methylprednisolone 1 gram by day for 5 days, but no improvements were registered, and they continue with 4 cycles of plasma exchange, also with no results. At that moment, they decided to refer it to our clinic, where we have seen the situation that I have said it at the beginning. When we investigated, so admission examination showed no general findings. From neurological point of view, he was awake, alert, oriented. But from pathological findings, we could observe a bilateral facial nerve involvement with attenuated forehead skin folds bilaterally, signed and attenuated nasolabial fold. Tetraplegia with hypotonus in all limbs, and also hypo and areflexia widespread. Meantime, he had pain sensibility disturbances of peripheral pucker, socks and gloves, and positive elongation signs. It is to mention that no pathological signs, meningeal signs, neither speech disturbances were registered, and he had normal bladder and rectal function. We continue with laboratory evaluation, diagnostic procedures, registering a mild neutrophilic leukocytosis and the elevated sedimentation rate and C-reactive protein. His urine analysis also showed some mild bacteriuria and leukocyturia, so which can explain the blood analysis also. His blood chemistry showed mild elevation of liver and pancreas enzymes, and the chest X-ray was normal. We, of course, have done a CSF analyzing, and we have found a proteico-cellular dissociation with 2.05 proteins and 38 cells by visual field, mainly neutrophils. We have done oligoclonal band test, and with equivocal positive result, only 1 band detected, and a negative anti-aquaporin for immunoglobulin. We continue, we repeated actually the examination done by our colleagues in the regional hospital. So the nerve conduction studies have shown demyelinating polyneuropathy with secondary axonal loss, with severe compound muscle action potential reduced in amplitude, significantly increased distal motor latency, and very slow motor conduction velocity. In our clinic, we repeated brain MRI, this time with gadolinium, And we have registered, like you can see here, in the region of corpus callosum, multiple lesions, and also in the periventricular areas, all of them being enhancing. The spinal cord, the cervical spinal cord MRI also registers some modifications, some lesions in the C1, C2 projection, but that one weren't enhancing contrast. Our preliminary diagnosis was acute inflammatory demyelinating polyneuropathy with flaccid tetraplegia, bilateral facial palsy, and central nervous system demyelination. Like treatment, we started again plasma exchange, 6 cycles, followed by immunoglobulin of 2 grams by day for 5 days. And this time it was a success because we have observed improvement, neurological improvement with apparition of muscle force in all limbs. So from 0, switching to 1 2 points. And that from this moment, he started rehab course in hospital, continued at home. And from March to August 2019, he had a substantial improvement. So he was able to look after his own affairs without assistance with hands, very important thing because he was studying architect. But he wasn't able to walk unassisted. Well, everything well and good until the end of August, when a new relapse, a new exacerbation of his state appeared with weakness in upper extremities, followed by weakness in legs, until tetraplegia during 1 week, so subacute evolution of symptoms once again. He was readmitted. This time we have observed a little bit asymmetrical neurological modification with more pronounced distal weakness, but also in all limbs, still hypotonus plus hypertrophia in hands, hyporeflexia, areflexia maintained. A little bit less sensibility disturbances remained only in legs, the SOX pattern, but reduced vibration was registered both in hands and legs, more pronounced distally. Repeated all the investigation what you have done the first time, we have seen normal complete blood count parameters, urine still a little bit leukocyturia. CSF analysis this time showed more pronounced proteico-cellular dissociation, almost no cells this time, and still 2.44 proteins. Nerve conduction studies without changes, but a brain MRI with gadolinium enhancement, unfortunately I don't have the image, shows a new lesion in the periventricular region, right periventricular one. So what we have done this time, once again on a plasma exchange, but we added dexamethasone followed by prednisolone, and from the day 5 of treatment, the improvement was very good. And 2 weeks later, when he was discharged already, he was able to sit and use very well his hands. 1 month follow-up, so tetraplegia regressed very well to tetraparesis already. And at this moment, we started cytostatic treatment, and from the available one, we started azathioprine plus prednisolone. So this one continued for 2 months more. After that, switching to alternating days prednisolone, reducing doses of prednisolone, and finally in May he was prednisolone free. And on this slide, I want to show you the evolution, very heavy evolution of our patients. So this is the situation almost at the discharge from our department. He switched to rehab unit. So you can see that he needs bilateral support plus 1 more person to help him in walking, but good use of hands. And this is the situation from May, when he was already prednisolone free and remained on azathioprine. And you can see that he can walk with unilateral assistance. So it's a little bit, he wants to be more secure because he can walk by himself also. And how, given the gait pattern, you can observe that the distal paresis of the legs is preserved. So our final diagnosis at this moment, we said that is atypical chronic inflammatory demyelinating polyradicular neuropathy and central nervous system demyelination. This fact, this diagnosis is argumented by the fact that up to 1/3 of cases, the CIDP can manifest with demyelinating involvement of the central nervous system. And given the clinical evolution of a patient, we have searched the literature data up to 20% of patients may have an acute onset as in Guillain-Barré syndrome. So actually, when at first admission, so that was our clue, our clinical thinking, given the time to nadir, the disease course, time to onset, plus cranial nerve involvement, we suppose it like acute demyelinating polyneuropathy. But after that, given the progression of more than 2 months, weakness, more than sensory symptoms, quite symmetric involvement of arms and legs, at least at first time. After that, it a little bit changed. We considered like CIDP. Of course, not all clinical criteria fulfilled the diagnosis of typical CIDP. That's why we thought about atypical variants, and from the most frequent one, like Lewis-Summers syndrome, sensory predominant form of CIDP, or the distal acquired one, nodal paranodal antibody mediating polyneuropathy. So we thought it is possible paranodal nodal antibody positive neuropathy, given its acute subacute onset, severe and nadir disability, predominantly distal motor weakness in evolution of a disease, presence of cranial neuropathies. And one important moment here is the treatment response. So like you have observed in the beginning of the presentation, the patient had no good response to immunoglobulin and plasma exchange. After that, when he was readmitted, this was a better answer, and he presented good response to corticosteroids at least the last time. But we do have to keep in mind that our patient has not only peripheral nervous system disorder, he has a central nervous system debilitating lesion. And so in this case, the combination of these two situations, we consider it like a possible situation of a so-called combined central and peripheral demyelination syndrome. This is a rare disorder, of course, and based on data derived from case reports or small case series. And patients presenting this situation usually have a worse prognosis than separate entities, and it's still on debate is that separate diseases, MS and CIDP, or it's something common, sharing a common immunopathogenic mechanism. So while searching for this common immunopathogenic mechanism, one important common thing is our presence of antibodies to neurophysin. So these are expressed both on central and peripheral myelin and involved in axoglial coupling at the paranodal regions which flank the node of Renthe. So in smaller case series studies that they have been found both in MS patients, both in CIDP patients, up to 10% of CIDP patients present these antibodies. And this can be a common feature, maybe present in our patient, because unfortunately at this moment we cannot test the presence of antibodies to neurophysin or contactive associated protein in our countries. And while fulfilling like criteria for dissemination in time and dissemination in space in our patient, plus peripheral nervous system demyelination for a typical CIDP, we don't have a final answer what is the exact diagnosis in our patient. And what is the long-term prognosis in this situation, even if he answers very well to the actual treatment on azathioprine, we have the open question if it's possible or necessary maybe to switch to another therapy, for example, to rituximab, because according to literature data, it shows a good answer both in atypical CIDP and in CCPD patients. That was our case. Thank you for your attention.
Thank you.
So thank you for this spectacular case. I think it's interesting that both of us, I think your case was much more interesting than mine, but address an issue of this overlap and the newly emerging field of antibody-mediated diseases of both the central nervous system and the peripheral nervous system. And it seems that this group of diseases associated with pathologic antibody response is not observing the boundaries between central and peripheral nervous system as clearly as we see that in MS or in the typical CIDP, where we assume that there is a more pronounced also T-cell response. So I think it's very important, and I would put that into the category of antibody-associated or unknown antibody-associated disease. And I didn't, maybe I've missed it. You did NMOS anti-aquaporin antibodies
yes,
and anti-MOG antibodies also. Anti-MOG were also
Anti-MOG,
negative.
no anti-MOG.
Maybe this would be interesting to follow up, and also neurofascin in an external lab. Although now in a state of remission, the diagnostic yield is less, but this would provide additional reassurance, I think. And maybe also be interesting regarding your key question, what to do now. No? Pragmatically, I would say as long as you see that there is a stable and perhaps even further recovering condition, I would continue with azathioprine. With the dose that you use for azathioprine, I was somewhat astonished because this is lower than 3 times 25, so 75, and it didn't seem to be so small. You know? The patient, we would usually take a dose of 2 to 2.5 milligram per kilogram body weight in order also for long-term.
Actually, we increased the dose. I didn't mention it. So it's, we start with the low one, but we increase it later on at the target dose. So it corresponds to
there is no good marker for the sufficient dosing. Of course, if no leukopenia or lymphopenia occurs, what we take frequently is the mean corpuscular volume of the erythrocytes as compared to before treatment. If this increases, then we assume that we are in the dose that is also effective on the immunological disease. But of course, this is only based on experience, and this but could serve as a laboratory marker as far as you don't have anything else that suggests to reduce the dose again. I would continue on azathioprine, but see also in conduction velocities and clinical observation if there is again a relapse in spite of this treatment, then I would go for a more effective treatment like anti-CD20. But azathioprine is certainly a good, has also been a quite valid treatment for NMO, for many years until the antibodies emerged.
Thank you.
Thank you very much. An interesting case. We are lucky that he is not so bad, so his clinical evolution is more or less positive, because otherwise he was several months tetraplegic, so you can imagine.
Yeah, of course. But the progression and also the perhaps residual deficit seems to be acquired by relapses. And so this again speaks against the typical evolution in someone. You could say it's MS and something else, but I think for an antibody-associated disease, this is quite typical, and therefore I would stay on this line of with the diagnosis and also with treatment attempts.
Thank you very much. Okay, then perhaps we can make a break, or you want to present another case?
Okay. Yeah, I don't know how much time we have, because I think you changed the program in order to have the workshops sequentially.
So until the next presentation, we have 20 minutes.
Okay. Perhaps one case to learn what you would think about that. That's a very short one.
Okay.
In the spectrum of elder patients. Let me see if I get it here. Excuse me. Now I cannot share my screen, but I will try once more. Excuse me. To get to the right point. Yeah. Let's see. This is a treatment, a patient with relapsing remitting MS initially, first manifestation in 1977, and now 78 years old. And you see she had been on Avonex treatment, then interrupted, and then had some signs of activity, and also an increase of the EDSS, which started from 3. That's when she came to our center, and then continued over the next few years with an increase up to 5 under Aubagio teriflunomide. I don't know if this is available in Moldavia as a treatment. So in this situation, what would you do? She presents without a relapse, but on a regular MRI. She has one new lesion in this area, and of course a few lesions that you see here in the FLAIR image, and this new lesion was also enhancing with gadolinium. Would that be a candidate for an escalation of treatment? You can argue she's already quite old.
Yes.
She may have also signs of immunosenescence, which means that the complication rate of a more intensive treatment would be perhaps high, but still she has a slow progression and she still has a good quality of life. So what would you have decided in this situation? You may have seen in the previous scheme that I showed that at the end, after consideration of the pros and cons, we decided, and this was already in end of 2018, to treat her with ocrelizumab, which was then recently available, and not in the normal indication because she was not anymore relapsing. She was in a secondary progressive, and the official indication is primary progressive. But taking this, the liberty and the option that was available, we treated her with ocrelizumab with the usual scheme. And since then, she has had no complications. She also reported at our regular examinations that she didn't have any increase in her disability. So this is, of course, a case rather at the end of the spectrum of indication where we still consider such a treatment.
So she receives ocrelizumab till now?
Yes, yes, and we are now reconsidering if we can extend the interval, so continuing on the same drug, and instead of the 6 monthly intervals, go again to 9 and perhaps 12-month intervals. That is the decision that we haven't yet taken up to now.
The dosage is the same as for a young patient, or
yes,
the same?
The same. She is depleted by B cells at the next interval. So as we now consider to follow if she's still depleted after 9 and 12 months, and to extend the intervals, but continue on this treatment that she tolerated very well. She is in an otherwise good general condition.
It's interesting. We have, of course, several patients of this age with multiple sclerosis, but we are unable to give ocrelizumab. Some of them are on cyclophosphamide, and still mitoxantrone is used. And as you have heard, azathioprine is used, and there is a recent publication that it could be used because it's quite efficient if the medical insurance system doesn't cover with more expensive drugs. So in our country, almost all the drugs are registered, but not all of them are covered by the insurance.
I understand, yeah.
So the patient can, they have other sources of, in their budget, they can buy the drug, and we can indicate this.
Yeah.
But unfortunately, it's not covered till now by the insurance company. Hopefully, in the near future, we'll see.
Yeah, let's see. Yeah, perhaps also the prices will go down, and hopefully, and I think we need also the more to weigh to the different costs, the cost to the society, the cost to the patient, and the cost for the drug in a better way, and with also better assessments. That's of course a line that of development that we, if we want or not, will need to follow, and hopefully also to be involved in the decisions associated to that. Yeah. Okay. So
thank you
I
very
have
much.
I have a
Yes.
small questions if you
Please.
have some time. How often do you see patients with the multiple sclerosis, but just psychiatric manifestation?
Yeah, that is an interesting question that was already covered in a publication, I think now more than 35 years ago, by Mrs. Poser, Sigrid Poser and colleagues, the so-called encephalitic version of multiple sclerosis. It certainly exists, so that, but is interestingly only seldom the case. But if the other criteria by MRI, and also in this case, I would also insist on having positive CSF findings, I think then we can assume the diagnosis, which of course then for the treatment might be difficult depending on the psychiatric disease, because these patients are not so compliant. Perhaps candidates also for these pulse therapies where you do something when they consent, and then you don't need the continuous collaboration so much as with daily intake of perhaps or twice daily intake of drugs. But I think it makes sense, and we have seen also people recovering from the psychiatric disease. Sometimes it is a comorbidity, and we just discover an otherwise clinically latent multiple sclerosis. That's not easy to differentiate.
We have a question, Professor Lisnik.
The question is coming from Pavel Gabrieluk. Is there an increased risk of PML in patients receiving ocrelizumab with increasing age?
Yes, both theoretically, and the one case that has been described up to now without natalizumab or other treatment or fingolimod treatment previously was in a patient who had a slight leukopenia on one side, but also was older. So yes, theoretically yes. In practice, only one case that I know of. So it's very difficult to tell. Yeah. And of course, it's one of the arguments why one could be more conservative in these patients. But on the other side, they're reserved to resist or to recover if something occurs from the disease itself is also quite serious, and therefore we need to consider both sides.
Had you to change the treatments in the COVID era? So sometimes you have to take into account that especially B-cell depleting therapies could be dangerous for these patients.
Thank you for asking that. That is indeed a reason for concern, because the risk of infection with COVID is higher in patients with anti-B-cell treatment, and also the effect of vaccination is attenuated. It's not diminished or not deleted, but it is attenuated, and patients may need a booster, an additional booster of the vaccine. Up to now, the evidence is not conclusive that the cause of the disease is different, so that it is more serious than in patients who are not treated or have other risk factors. In relation to that, the increase is not more. So from this point of view, this is again reassuring, but I think, as we say, the jury is still out on that, and it is perhaps at the moment the only consideration that reduces our optimism with this therapy. But up to now, it's not. There is no clear picture. No.
Thank you very much, Professor Kapos. I see there are no more questions, and we will not take your time from the holidays, and we wish you a pleasant afternoon today. Perhaps.
Thank you, and good continuation of your Congress. All the best. Yeah. So start of your official Congress, I think tomorrow. All the best, and hopefully at some time from with direct contact. Bye bye.
Thank you very much, and wishing to meet each other in a more formal situation at not a virtual Congress, and hope to see each other in Vienna next year.
Bye bye.
Bye bye. Dear colleagues, we have a 10-minute break, and at 15:30 we are waiting Professor Witzdorf for the last workshop. 10 minutes break. Thank you. We have 35 seconds more.
We are resuming in a moment, yeah?
Yeah. We had a small break.
Okay.
Can I continue?
Yes, shall I go?
Yes.
Let me just have a sip of water. Okay.
So, dear colleagues, let's go to our last workshop. It was a full, interesting day, and the last presentation, I think, could be the most interesting one. Professor Bisdorf, I'm sure, will speak about the possibility of clinical examination of the vestibular system, which is not an easy one. Thank you.
So thank you. So I go ahead. Let's see. That's it. Okay. I hope you can see.
Yes, we see.
We see. Okay. Well, welcome back. So it's my pleasure and challenge to keep your attention for the last hour of this meeting. So I was asked to give something about how to examine a patient with vertigo. Now, what you all do and what is for neurologists, I think, pretty normal, for ENTs probably less, is that you have to watch how people walk. Neurologists are usually good at recognizing apraxia, cerebellar gait, extrapyramidal gait, spastic ataxia, and so on. So that is already orienting you to some extent. But if you see just somebody very cautious walking, or then you have a balance problem where you cannot say much more about it. If somebody doesn't stand in the Romberg test, then you know he has a globally bad postural performance, but you cannot say much more. Obviously, oculomotor examination is very important, and that is what I'm going to talk more today about. And also about the head impulse test, which I think every neurologist should have an idea about how it works and train it to use I think on a daily basis. Now, we talked this morning about vertigo and dizziness, which can be spontaneous or can be triggered. And I wanted to point you out a few things which are important to understand, because they mean not the same. We have head motion versus positional versus orthostatic. So any of these tests or situations involves a head movement, but they mean not always the same. So, for example, the top one, head motion, vertigo or dizziness, would be a dizziness or vertigo which happens in any kind of head motion. It could be linear, it could be rotation, but any plane, any direction in space, whereas positional is actually meant that you change orientation of the head versus gravity. So for example, if you take, I don't know if you see my mouse, if you take here the middle one where the person lies and then sits, that is a change of position. Whereas when you turn your head when you are sitting, that is not a change of position, because the orientation of, sorry, I have to go back. The orientation of the head in space does not change. Whereas if you turn your head when you are lying down, that is a change of position. So if somebody says, I'm getting dizzy when I turn my head right and left when sitting, does not mean the same than when I turn right and left when lying. One is head motion plus positional, the other was only head motion. And on the bottom, we have the orthostatic. So orthostatic is when you rise up from low to higher. And on the left hand, you see the head going just up. On the right hand, you have somebody who goes up plus a positional change, because he changes orientation to gravity. But the things don't mean the same for the vestibular system. And in your examination and your history, you need to tease out, because orthostatic, purely orthostatic, will obviously more be cardiovascular. Positional can be benign or non-benign position vertigo. And when you have a head motion vertigo, that any kind of motion provokes a symptom, that means that something is wrong with the measurement of the head movement. Doesn't tell you anything more. You should know something about how to call nystagmus. I think that you all know. Any nystagmus is a rotatory movement of the eye, which is a globe. It just depends on what axis you are rotating. So a lateral movement rotates along the long axis, vertical, the horizontal axis, and the torsional, the sagittal axis. So don't use rotational vertigo, because they are all rotational. Use torsional vertigo for the one who is in the sagittal axis. While you have an idea about the inner ear, you have the semicircular canals, you have the otoliths, they have different kinds of information, rotation, the other one linear acceleration. Will not go much into that. The semicircular canals detect motion as an acceleration. So when they move in the plane of the canal, the endolymph will push or pull against the cupula, which deflects, and that is the signal which goes to the brain. And the otoliths, they have these cils, sensory cilia, which deflect according to linear acceleration, which can be actually a linear acceleration or a tilt. Signal is in that sense the same. These are in French, I'm sorry. And then it also helps to know how the different canals are oriented in the head. So you have the anterior, posterior, and lateral canals, and they always work in pairs. So the anterior on the left is in the same plane as the posterior on the right, and the anterior right and the posterior on the left. And the two horizontal ones are in the same plane. And then you on the right-hand side, you have an idea of how that is placed in the head. Now, in a normal situation, and here's a scheme now for a horizontal canal, if you are at rest, the vestibular nuclei, which are represented here with the orange dots, they are not silent. They have a basic firing rate. So even if there's no movement at all, they are busy. And when you turn the head to the right, then you would stimulate on the right and inhibit on the left. And that will have an effect on the activity of these vestibular nuclei. So one goes up, the other one goes down. There's also an interconnection between the two. So if one goes up, it inhibits the other one, and inhibition of one side excites the other one. There's a push-pull situation. And if that happens, the person will feel that he turns to the right, and there could be a nystagmus which goes with it. and that's the correct perception. Now, the vestibulo-ocular reflex is there to stabilize gaze in space. So if you have a head movement, here again to the right, the eyes need to make a movement to the left, which matches exactly the head movement to keep the target on the same spot of the retina. If that doesn't happen, you lose your target from the side, and you could have this retinal slip with blurred vision or oscillopsia. And that is a reflex which is very fast. It has a 12 millisecond latency. So in a high range of frequencies, it will be very precise. Now, when you now move your head in space, you will excite one side, you will inhibit the other side. And the inhibition goes then that the resting firing rate will decrease. That means that in fact, each side can measure both directions. So if you move to the left will increase and the right will decrease. So if you lose one side, in theory, the one side could measure you both directions, could measure by, if it goes down, it means it rotates to the other side. If it goes up, it means it rotates to my side. But that system is not only works correctly at low speeds. If you go into high speeds, you have the following problem. The basic firing rate, which is here symbolized with the black line, inhibition can go down to 0, but it cannot go further down to 0. And excitation can go very high up. So in fast movements, excitation will be much higher than the inhibition ever can be. And that means that at fast movements, only the excited canal actually measures correctly. The other side cannot measure that correctly anymore. It's only valid in slow movements. And that is something which means that compensation in case of a lesion can never be complete, and we can also use that as a clinical test. So that is a famous Halmagyi test. So when you look at the patient and he moves quickly to the left, the eyes stay on target, and you ask the patient to look at your nose. And when when it doesn't work, it will be different. So here again, an explanation in a different way. The examiner asks the patient to look at the nose. When the head is moved to the right side fast, the right semicircular canal will be the one which is tested, because the inhibition of the other one is not enough to detect that properly. And the eyes will stay on target because the vestibulo-ocular reflex is so fast that it will ensure that. Now, if you have a unilateral lesion, for example, a vestibular neuritis, which is an acute onset of sustained vertigo, you will have a peripheral type of nystagmus, which is always beating in the same direction. You have a proof of vestibular lesion, no hearing loss, no neurological signs. So what are we going to do with that? So the physiology, which is simplified obviously here, will be one side lesion on the left side. So if no signal comes in from the left side, the firing rate of the ipsilateral vestibular nucleus goes down. The other one goes down a little. That is a push-pull connection between the two. But it means that the right side is more active than the left side. And for the brain, it means I'm spinning to the right. So you have, if a lesion is on one side, you will have the impression that you spin to the right side. And also there will be a nystagmus in the same direction. Now, what are the characteristics of such a nystagmus? Well, it is normally a lateral nystagmus. That is because usually it is a lesion of the nerve which connects the lateral canal. There are very rare vestibular neuritis which have the other canals affected in isolation. And that nystagmus will not change direction. You can look in any direction, it will always be in the same direction. You can lie people down, you can sit them up, it will not change direction. It may increase if you look in the direction of the fast phase, or decrease if you look in the other direction, but it will not change direction. If you look at it in the dark, it will be usually faster than in the light. And it beats in the direction of the healthy ear. That will be the characteristic. And then you need to prove that one organ is not, vestibular organ is not working properly. And for that, we use to see if there is a deficit of the vestibulo-ocular reflex. And I will show you here the bedside examination, not the test-based examinations, which is the video head impulse test or the caloric test, because that is maybe a different lecture altogether. So here we have now the left-sided vestibular deficit in a schematic way. You have the person looking at, you turn the head quickly to the left, and because the ocular reflex doesn't work, you see that the eyes go with the head. Then the patient notices that he lost his target from his sight, and then he will redirect the eyes to the examiner, and then he makes a saccade. You see, then he looks and then there's a saccade you can observe. You see it again in this scheme. So now we have a right canal which is lesioned. You move the head quickly to the right, and here you see the eyes went with the head because the reflex didn't work. The patient notices that he lost the target, and then he will redirect his gaze to the examiner's nose, and that is the correcting saccades which you can observe as an examiner. Now we're going to see if we can watch that a bit. So here you see the spontaneous nystagmus to the right, and you see he looks to the right, it stays right, he looks to the left, the nystagmus stays, always a right nystagmus, looks down, it is a right nystagmus, he looks a bit up, it is a right nystagmus. So now I try to do the Halmagi test. And so when you go to the right, the eyes stay pretty well fixed, and he goes to the left. You can sometimes see that there is a delay, but it is very difficult because the fast phase of the nystagmus obviously is also there. So it is very difficult to tell, am I now seeing the fast phase of the nystagmus, or am I seeing the catch-up saccades of the deficit of the vestibulo-ocular reflex? Everybody agrees that that is very difficult, and even for experts, it can be very difficult. That's why in such a situation, a machine-based test has absolutely its place, either with a video-based system or with a caloric test. But I will show you examples where it is better to see. So this was a man with a vestibular neuritis in the acute phase. And here, I think it's the same man a bit later. Now you see the nystagmus is no longer so active. And then it becomes still the same issue. It doesn't stop beating in the right side. When you look to the left, it was not so prominent, that is normal. But here you now can see a bit better. Still not easy to see a catch-up saccade, because it's a bit bigger than the nystagmus. But I also agree it is difficult to see. Okay. Now I'm going to show you another case of a lady. Oops, go back. There it is. So here we have only very discrete spontaneous nystagmus, and that makes it easier to see that. So now I ask her to fix my nose, and now we're going to move. So she also has a lesion on the left side. So when we move to the left, if she cooperates well, because people are not always easy, there you had one. There you had one. There you had one. So I hope you agree with me that this time it was more obvious to see. I can play it again. So you see still a discrete right nystagmus. And now, oh, that was not very clear. That was not very clear because you closed the eye. There it was clearer. There. And when I moved to the right side, you could not, there was no catch-up saccades. The eyes stayed oriented on the nose. So why is that so important in the acute phase? Because if you have a cerebellar stroke, you can have a clinical picture which looks exactly like a neuritis. So it is a acute onset of sustained spinning vertigo, and you don't have additional neurological symptoms or signs which will make it easy to identify that it cannot be a neuritis. Because if you have a hemiparesis, if you have double vision, if you have speech problems, we know it cannot be neuritis. This is a landmark paper which was published, as you see, in 2006, and that was a series. And they looked at cerebellar strokes, most were pica strokes. And if the brainstem is not included, then it can present as similarly to a vestibular neuritis. Because if the brainstem is affected, you usually have long tract signs, or you have other caudal nerves affected, and then the distinction is a lot easier. And so it is now when somebody comes to emergency with an acute spinning vertigo, it is obviously not a banal question to ask, is it now a cerebellar stroke, or is it a neuritis? Prognosis, prevention, and so on are all very different. Now, how can we get around to try to sort that out in an emergency situation? And there has been developed the HINTS, three-step oculomotor examination. HINTS stands for horizontal head impulse test, nystagmus, and test of skew. And it has been shown that at least with the MRI's quality of that time, 10 years ago, it is in expert hands, can be better than an MRI, even diffusion MRI within the first days. Because if the lesion is small, MRIs can be blind, and it's certainly much better than a CT scan. Now, what is HINTS? Just explain it. So, head impulse test, we already discussed it. Nystagmus, we also have discussed it. So, you look at somebody's eyes in a straight ahead gaze. You look if there's a spontaneous nystagmus. Then you should also, if possible, look the eyes under Frenzel glasses, because the peripheral nystagmus might become more visible in the absence of fixation. And then you ask the person to look to the left and to the right. And what you want to look is, does the nystagmus change direction? We saw just before examples where it didn't. So we are then in the peripheral sense. The central sense, that can be different. And you also look for skew. That means that there is a vertical deviation of the eyes, and that without an oculomotor paresis, and that is a central otolytic sign, so of the gravitational path. Now here I will show you an example of a skew. So a skew means that there is a vertical deviation of the eyes, and here the right eye is higher than the left eye, but the lady has also other abnormalities. So this one is not a stroke patient, isn't a MS patient, but it is. I chose it because it is an illustrative example. So we're going to look at that. So I asked her to look. So you see there is a nystagmus to the right and a nystagmus to the left. So here we have a direction change in nystagmus of gaze, okay? Now I cover one eye, and then when you change the cover, you look if the other eyes make a correction. Now here you saw that the left eye went up, and there the right eye went down. It isn't the shade, I agree, but I can play it again to make it that you can have a chance to look at it again. So first, I look at the if there's gaze evoked nystagmus. So here we have a right beating nystagmus on left right gaze, left beating nystagmus on left gaze. And now the left eye is lower than the right eye. So it went up because I covered the right eye. That comes down when I cover the left eye. Now I'm going to cover the right eye, left eye goes up. And that comes down. Okay, I hope it was visible. Yeah. So you had here a skew deviation. Skew deviations also exist in peripheral diseases, but they are so small that you cannot see them like that. If you see them like that, it's central. So here is now a man with a stroke. This is not in the super acute phase, a little bit later. And we're going to see what we see here. Like this, okay. Now we're going to go close to the eye and we see what we find. And I hope you can all see it. There is a nystagmus which beats upwards. Okay, and there is a nystagmus which also beats upwards. Might not be so clear than on the other eye, maybe because the focus was not so good. So if we are in that kind of thing, we are already not in the peripheral thing. Now, if we look at when he looks to the left, you see that the right eye doesn't follow. So he has an internuclear ophthalmoplegia. I look here for the skew. There is not much skew to see in his case because he has his upbeating nystagmus. There is a little bit because the eye comes down. I think I play it again because what you need to see here is, no, hold on, it's not the same. Yeah. You see the upbeating nystagmus, spontaneous nystagmus upwards. We are away from the peripheral thing. Very clear. Horizontal nystagmus can be peripheral or central. Upbeat nystagmus is not peripheral. That doesn't exist like that. So now I ask gaze, and you see here, I go back again. So when he looks now to the left, you will see the right eye doesn't follow. So that is an internuclear ophthalmoplegia on the right side because the adduction is limited. To the left, in right gaze, you didn't see much of a INO on the left. So I try the skew. That is not much of a skew to see. Maybe a little bit left on right. Okay, and now here's the same patient where I do the head impulse test. So except that when I go to the left, when I go to the right, we can still see something like the INO because the right eye doesn't follow. but he doesn't have catch-up saccades. So this Halmagyi test is normal. So if you have a normal Halmagyi test, that is what is suspicious. The abnormal, you are in the peripheral sense. Normal is suspicious of central. And he had a tiny stroke, which is pointed out here, which had been overlooked in the first image by the radiologist, by the way. And here it was clear that the eye movements were very clearly abnormal, and you could tell what kind of vertigo that is. So, again, nystagmus, horizontal nystagmus, which does not change direction with gaze or head position, reassuring, we are in the peripheral area, vertical, purely torsion nystagmus, or nystagmus which changes direction, central. Here's another one of these stroke papers where it was shown that the hint test can be more sensitive than an MRI in acute stroke. Now I come to another clinical scenario, bilateral vestibulopathy. That is when you lose vestibular function of the ear on both sides. That is a chronic vestibular syndrome. It doesn't happen as an episodic syndrome. It can happen as an acute, but that is very rare. Usually it is something which sets up, we're talking about the reasons a bit later, but it is normally not something which comes about very acutely. And the patients will not complain about vertigo, because if you have a loss on both sides, you don't have this imbalance in the vestibular nuclei, and you don't have this illusion of spinning to one side. So they don't complain about vertigo on a whole, but they complain that they are unsteady. When they walk, when they stand, when they lie down, then they are fine. When they sit down, normally as well. When they move their head, because their vestibular ocular reflex will not be functioning correctly, they can have vestibular visual symptoms like oscillopsia. So they walk and they see the world bouncing, or it gets unclear, so that they get the blur. Usually the unsteadiness is worse when it's dark, then they have not the visual help for their balance, or when the ground is uneven, then they don't have the good proprioceptive input from the feet. And then you need to show that they have lost vestibular function on both sides. And obviously you have to watch out for differential diagnosis. Now here we have a lady, next slide. Yeah. So this lady, I will show you the video. This. Obviously, there's no spontaneous nystagmus, and now we see left side abnormal there, catch-up saccades, and the right side as well. It's not always visible, but I hope I can convince you that you could at least see it at some occasions, that depending on how that there was a deficit on both sides, has been proven also with machines afterwards. Some patients learn to do these catch-up saccades so quickly that you cannot detect it with naked eye. You can only detect it if there's some latency between the head movement and the generation of the saccade. When the saccade is generated in less than 100 milliseconds, then it is called a covered saccades. And covered saccades can only be detected with the help of a machine, with a video head impulse test. I think I play it again because it's good to see it again. There it was not visible, there it was visible, there it was visible, there it was visible, there it was not visible, there it was not, there it was, there it was, there it was, there it was, and there it was. Okay, when I go closer, doubtful visible. There it was. There it was. There it was. Okay. I know it is not easy. It takes some training, but there are quite a few false positives and negatives also amongst experts. So we know it is not so easy to know that way. When you see it clearly, like in her, we are sure, but sometimes we are not. So bilateral vestibulopathy does not provoke vertigo, but it's still a vestibular disease. Many times we don't know where it comes from. Important reasons are ototoxic drugs, and from that it is mainly antibiotics, like gentamicin. So after severe septicemia and staying in intensive care, and people have to get these drugs, some wake up and from coma and are very difficult to mobilize because they are very dizzy, and part of those have lost their vestibular function because of that. And then the mobilization is really much more tedious, take much more rehabilitation, and you can never fully compensate that. People with bilateral vestibular loss, they can, for example, no longer run a motorbike, because if you take bends, you need to lean into the bend according to the centrifugal forces and to balance it against gravity. And for that, you need your otoliths to measure that. And if you don't have them, you don't get it right. So these people usually have to stop motorbike, for example. And they have a lot of other potential problems in daily life. Other reasons are systemic disease. There is canvas, which is a combination of vestibular degeneration and loss of vestibular function. Can be after trauma, if you get a bilateral fissure in the petrous bone, bilateral schwannoma in neurofibromatosis type 2. And as I said, the other senses cannot fully compensate for it. There's no useful drug for it. The only thing you can do is to try to teach coping strategies with vestibular rehabilitation. And hearing aids have been around a long time, but vestibular implants are now under development and may come in the market in the next 10 years. And then we need to see what are the really good indications for it. And then I will come to the benign positional vertigo. And that is something you really need to learn as well. So I have again a scheme of an inner ear. So these otoconia, they are attached to the otoliths. Normally to the utricle, the saccule is separated from the rest by a very small duct, so there is normally no connection. But the otoconia, which are attached to the utricle, they can get detached and fall into the semicircular canals. And then what happens is that they change the these physical properties of a semicircular canal, which usually only detects rotation in its plane. And now it becomes position sensitive. And then it changes totally how it works, and then it makes a vertigo. So here's a scheme of that. If you lie, here's now a model of a semicircular canal with a cupula. And here the otoconia are in the endolymphatic, the endolymph space. You are lying at rest. So when you move now the head 90 degrees to the left, then the otoliths will start to move down gradually, and that movement will provoke a flow of the endolymph, which itself will then make a pull on the cupula, which is a signal for the brain that you spin. Although you don't spin, you just change position. But that will not last long, because the otoconia will then settle on the lowest part of the semicircular canal, and then the vertigo stops, and the nystagmus as well. And that duration is between a few seconds up to a minute, rarely longer. And then when you move again, it can come back, obviously. If you repeat the movement, the otoconia go into dispersion, and then the effect when you change position does not come anymore, or comes very weakly, and that has a big clinical consequence. Not only that when you test it, you have a chance to see it once, and maybe if repeat it another time, but if you repeat it several times in a situation of examination, you will lose it. And also, if people have already moved a lot during the day and they come to your examination, you might not be able to provoke it. Then you cannot say it's excluded because you couldn't really see it on that moment. So the characteristics of the vertigo and the nystagmus there's a little latency. When you change position, it takes a few seconds that the crystals start to move. Crescendo, decrescendo means they start moving slowly and then they settle down slowly. That is the crescendo, decrescendo. It's transitory, less than a minute. Anything which is less than a minute is called paroxysmal. It has this phenomenon of fatigability, so it reduces. And the direction of nystagmus corresponds to the semicircular canal. And for that, you need to know the orientation of the canals in the skull and how it translates to an eye movement. We're going to look at that as well, because the most common one is the posterior canal. Why is that? Probably because when you lie down, it is the canal which is the lowest, and the crystals have a higher probability to fall into that one. That is the simple physical explanation. And it's also why a BPV nearly always starts at night or in the morning when you get up. A BPV starting during the day, you have to be very cautious. A vertigo starting during the day is rarely a BPV. The vertigo starts at night, when you turn in bed or when you get up in the morning, is very likely to be a BPV. But it's a short vertigo. Sustained vertigo is not BPV. Now here you have a model of a patient, how you do the test. You sit in, and then you turn the head 45 degrees to one side, here to the left. That brings the semicircular canal, as you can see here on the bottom, in the sagittal plane. And when you lie down, then you really stimulate this canal, and you make the otoconia move. And then you get a nystagmus, which is in the plane of that canal. And when you look at the orientation of the canal and the eye, you provoke a vertical and a torsional movement. And that we can illustrate. I think it comes here. And this is a model done for pedagogic reasons. And there you see different things. First of all, we see the direction of the nystagmus. So it beats up, and it has a torsional component to the left. Left because the upper pole of the eye beats to the left. We could see something else, and I'm going to play it again. There is also the crescendo, so it goes up, becomes more violent, and then it goes slowly down, decrescendo. Okay, appreciate that. And now I'm going to play it again, and now you watch both things. Going to watch the direction and the crescendo and the crescendo, and that's it. So that would be a typical one. Sometimes it's longer, sometimes it's shorter. Now this is obviously not a real, it is based on a real patient, but it is modelized. The real patient might close his eyes, scream, be fearful, not cooperate as he should, and so on. So things in real life are not as ideal as here, but to put it in your mind what the nystagmus looks like, I think that is how it is for a posterior canal BPV. We have situations when the crystals are not floating in the semicircular canal, but are sticking to the cupula, and that is called cupulolithiasis. And that changes also the situation, because then obviously there will be no movement of the otoconia in the canal. And if you bring the canal in a direction that the gravity will pull on the cupula, you will have a vertigo and nystagmus which lasts as long as you put the head in that position. So it will not be a paroxysmal vertigo. It will not be only short. It will be as long as it stays in that position, and it changes direction according to orientation in space. So if you have here a lateral canal, cupulolithiasis, and you turn the head, for example, here to the left, because here's a pull of the cupula down, the nystagmus will beat upwards, which is called apogeotropic. And then you turn the head to the other side, the same thing will happen, but in the other direction. And that kind of nystagmus was considered as central over a long time until 1995, when it was described by famous neurologist, Professor Barlow, that it can be a variant of benign positional vertigo. And since then, it has been well recognized. It is not so common, but it does exist. So this kind of cupulolithiasis has no latency. The intensity varies with the angle according to gravity, obviously. It is persistent and it changes direction according to head orientation. So theoretically, we should have canalolithiasis and cupulolithiasis for each canal, but we haven't recognized all of those. We have the canalolithiasis of posterior lateral canal are well established. Anterior canal, we are still a little bit shaky, probably exists sometimes. It can be uni or bilateral, and it can be one or multiple canals. If it becomes multiple canals, it becomes very tricky. Nystagmus can take very strange shapes, and also experts can get a bit lost in those. And then we have the lateral canal cupulolithiasis. Others have been tentatively observed, but we are still not so fully sure. The treatment is very efficient. It is called liberation maneuvers. And the principle is that you, by a sequence of head movement, you get the otoconia out of the affected canal. The canal is occluded on the side of the cupula and has an opening on the other side. And so you have to maneuver the otoconia in that direction, and then you can cure it. There's no point in giving drugs. And if you know how to do it, you can usually cure people in one or very few maneuvers. I have here the Apley maneuver for a left canal. And to explain that is now a bit tedious because an animated model would actually be better. And because then you need to know exactly how the canal is oriented in the head and what kind of sequence you need to do. And then you should also observe the eyes, because every time the otoconia move, you should actually make a nystagmus like in the beginning, but it can be much more weak. But these maneuvers are very useful, and in patients which have recurrent BPVs, they can learn those themselves and help themselves often quite well if they are physically and mentally good for it, because you need to be not too stiff, you need to be a bit mobile, you need not to be too anxious to do them, because it is provoking your vertigo. Never forget that. That is a self-apply. I will just, this you can find on the internet and download it for free, it's no problem. This is for the right ear, then you can do it for the left ear. That is then the mirror fashion. I think, yes, most cases are spontaneous, some are post-traumatic, and then they are often bilateral. And it is a recurrent issue because 50% of patients have a relapse within 5 years, and it is not necessarily in the same ear or the same canal. And there is no preventative measure which has really been properly established. So if you have a recurrent one, you either need to go back to the therapist or doctor or they need to learn how to handle it themselves. And I think that was it.
Thank you very much for such an interesting presentation. It's a difficult topic, and of course, I know a lot about all these maneuvers, but the general neurologist, I don't know how he's working in Luxembourg, but in Moldova, I don't think a lot of them practice these procedures in their daily practice. What you can say about Luxembourg? A general neurologist is doing all this?
Most are not. And I must say that even many don't even make the diagnostic maneuver. So I think a whole pike everybody should learn to do, at least to see, to provoke the vertigo and the nystagmus. Even if then you have at least a diagnosis or a probable diagnosis. The maneuvers can be quite complex, and you can also get complications of maneuvers, because sometimes the crystals fall in another canal, and then you can switch from a posterior to a lateral canal, and the physios who deal with this, they need to recognize this as well, because then you need to change the liberation maneuver to be efficient. I see there is a question of Olga Gavrilo, if the VOR can be impaired in BPV. If you have a lot of crystals in the lateral canal, it can, in theory, but it is usually not a big thing. If it is attached to the cupula, then it can be a bit more impaired. But VOR impairment in BPV is not normally not a feature. Another interesting thing, if I may take up this question, is if you had a neuritis on one ear and the nerve does not recover, can you still have a BPV on the same ear? I don't know if anybody has an idea. Talia, do you think you can have a BPV on the same ear when you have a neuritis? Because logically you would say, well, if there are crystals loose in that ear and you make a wrong signal, if the nerve is gone, it cannot transmit the wrong signal to the brain. Okay, that would be the logical thing. But somebody says yes, and the reason, and it is correct, it is because vestibular neuritis usually affects the superior branch of the vestibular nerve, and the posterior canal depends on the inferior branch. And so you can have the combination of a posterior canal BPV and a lesion from an old neuritis.
Thank you very much, Professor.
Any other questions?
Good afternoon, Marina Sangeli.
Hello, Marina.
Yeah. I want to ask you about how often do you see patients with multiple sclerosis and BPPV? Because according to the literature, we saw that there are a lot of cases, not so much as we diagnosed in our country. So what is your experience about this?
Well, I see that as well regularly. And unfortunately for the patient, if you have MS, they tend to make the experience that every symptom is put on MS. But MS obviously doesn't protect them against BPV. BPV is very common. I mean, a few percent of people every year have it, or we would guess maybe 1 or 2%. So per year. So you can imagine that the coincidence of MS and BPV must exist and does exist, and it is important to recognize it, because that you can really treat well, whereas vertigo from MS is certainly more difficult to treat. No, it does exist. And if you have somebody with MS complaining about vertigo and positional vertigo, think that they might well have that, and it is they can be well helped.
Thank you.
Thank you. Any other questions? Oksana.
Thank you, Professor. It was a very interesting lecture, but I am from the headache field, and I have a question about vestibular migraine. Do you consider that it's fair to take away vestibular migraine from the international headache classification?
It was not taken away. I think it was never properly included.
It was put in the appendix, and it's not in the whole main classification.
Yeah, but it was not taken out. No, I think it should be. The criteria for the paroxysmal vertigo of childhood, which has been extended to adults, is actually much more much less clear than the criteria for the vestibular migraine even. So there is a very loose, on the one hand, there's a very loose definition in the main classification, and there's a much more clear definition in the appendix. By the way, we have in the Barani Society worked now on an update of the episodic vertigo in childhood, which has been published recently. You find that in the Journal of Vestibular Research website for free. And Stefan Evers and Olsen are co-authors in that. So I think things will move, that we will update that a bit better than it is at the moment.
Okay, thank you.
Thank you. Somebody else? Okay, so thank you very much, Professor Bister. No, not tired, because it's only the middle of the day, so we have some time to prepare for tomorrow presentations, because most of us, of course, they are pre-registered already, but anyway, we have to answer the questions that can appear.
Okay.
Thank you very much. It was very interesting to hear your approach to such a difficult, I think, field. And anytime it's interesting to hear something else, and to how to approach these patients, which we see them almost every day, but we sometimes don't have the right decision for them. Thank you very much, and thank you for joining us virtually. We hope you will visit Moldova sometime, because I was telling we are sitting close each to other at these meetings of the EFNS and European Academy of Neurology, and you didn't have we didn't have the possibility to see us in place, but we hope this will happen maybe next year, maybe later. We'll see.
So maybe we will have one day a real workshop with hands-on training. Okay.
Thank you.
Good.
Okay, this is the closing of our teaching course of the EAN day. It was very interesting. Three different topics: stroke and multiple sclerosis and vertigo. We thank our invited speakers that they agreed and came with brilliant presentations. We will ask our participants to fill in the evaluation forms which are requested by the EAN, and we'll submit them, and after that we'll receive certificates of participation. Our speakers, if you want to come and to see what is going on with Moldovan neurology, you can join tomorrow. All this, you'll have the same link, and some of the presentations will be in English, but most of them will be in Romanian. Some of them will be in Russian, so you can improve your language skills. If somebody wants to tell something, Oksana wrote to everybody about the evaluation forms, so please go to this link and download them and complete these forms and send them back. So at the end, I will wish you strong health and hopefully we will not be touched by this pandemic or easy touched. Some of us were touched, hopefully without consequences, difficult, without very strong sequels, and hopefully to see each other at least next year in Vienna, and if not in Vienna, at another meeting. Wishing you great results in all your activities, strong health, and Moldovan colleagues, please do not forget to come tomorrow morning at 8:30 at the opening of the Congress.
Okay.
Thank you. Have a nice evening. Goodbye.
Bye-bye.
Vă rog mult să completați formularul de evaluare.